We will move on to our guest speaker, Dr. Rasheeda Hall. And very happy to have Dr. Hall with us. She's an assistant professor of medicine in the Division of Nephrology and the Division of Population Health Sciences at Duke. She did her medical school at Vanderbilt, residency, nephrology fellowship, and then an additional geriatric fellowship at Duke. And she's really one of the leaders in geriatric or gerontologic, I should say, nephrology. Her research is focused on a few broad topics, but covering improving quality of life for older adults, especially those on dialysis. And as a nephrologist, she leads the Durham VA Geriatric Nephrology Clinic. So happy to have you, and I'll turn it over to you, Dr. Hall.
Can hear me. Can you hear me?
I can hear you.
Okay, thank you for the invitation, and I'm just going to make sure I'm sharing the slides appropriately.
And I think just
and I need to swap.
That'll be great. And just for expectations,
We're good?
That looks great. And just for audience expectations, we're running a few minutes late. I'll expect to go 5 minutes over. Thanks to those who can stick with us. Go ahead.
Oh, great. Yes. So thank you for the introduction. Thank you for inviting me. I'm excited to share about something that's kind of been the focus of my work around geriatric problems in patients with kidney disease. And hopefully there's some pointers anyone can take away from this talk, whether you're only a clinician or also an investigator. The outline today, we're going to first talk about the significance of geriatric problems, and then talk about what we know as far as ways to manage them, and then strategies to overcome barriers to management. And I include this quote because for me, what drives me around doing this work is acknowledging that many of our older patients may be overlooked and under-recognized as far as their problems, and wanting to acknowledge their humanity, dependent on recognizing their humanity and how we care for these patients. So let's talk about the significance. We'll start with this slide. This is looking at geriatric problems in patients with CKD. As you can see here, as eGFR declines, so this is higher GFRs, lower GFRs, you can see that the number of geriatric problems increases. For example, you look at these gray bars, that patients are more likely to have more geriatric problems, at least 2 of them as listed in this box, whether that's cognitive impairment, depression, exhaustion, falls, and any difficulty with mobility or polypharmacy. And we don't see that just in CKD. There is also some data when you compare studies where we just look at the overall older adult population and studies that have focused on older adults who are receiving dialysis. You can see the prevalence of falls, cognitive impairment, frailty, and polypharmacy to be greater or more of a burden in the dialysis population than in older adults who are about the same age without kidney failure. Also wanted to highlight that we know the geriatric problems exist in our younger patients with kidney disease too, particularly if we just look at frailty, because we know frailty is a geriatric syndrome. And I listed here its main components. But really the focus of this slide is to acknowledge that in a study almost a decade old, that in that cohort, among the patients who are under 65 years of age, 35% met criteria for frailty. So we acknowledge that that's present. And for those of you who don't know, that frailty is a precursor from other geriatric problems, especially functional impairment. And so what we acknowledge about the significance of geriatric problems, you start with the patient themselves, that there's a significant impact on their quality of life, especially among patients who value their independence. And so having more and more dependence in activities of daily living, for example, affects their quality of life. And we also see how that can affect the level of care they need, right? So some patients may start to need home health, then assisted living, then perhaps nursing home care, as they have more and more geriatric conditions, or another way to say it, more dependence and activities of daily living, aside from other geriatric conditions as they start to accumulate. And it can seem like a ripple effect, because not only is it affecting the patient, it's affecting their family, the healthcare system with respect to cost. And we also know there's several studies that would suggest that patients with more difficulty with activities of daily living or functional impairment have a faster time to death. And in one of the studies I did a few years ago, we interviewed dialysis patients who are like age 75 and older about their quality of life. We looked at a couple of themes that stood out as what matters most to these patients, and these definitely relate to geriatric problems. Patients highlighted having physical well-being was extremely important, as well as having sufficient social support. And considering these factors, not only just what matters to the patient and the negative impacts of geriatric problems, there's a need to actually, not just acknowledge they're there, but what are we going to do about them? For me, I made this figure years ago to kind of frame how I see the types of studies I like to pursue. We have these vulnerable older adults with kidney disease. How do we get to improving their quality of life and those related clinical outcomes like hospitalizations and nursing home placement? We need to figure out how to manage their geriatric problems and do it. And it could be that we can tailor nephrology care too, and maybe they work together. And a lot of work I've done to date has been around managing geriatric problems. And so the next few slides are going to get into that. Now, before I switch topics, I do want to acknowledge that I can't see the chat if someone's asking questions. And I do recognize I've got a short time, but if there's a need for clarification, please feel free to interrupt me. So let's talk about geriatric assessment, because I think from the geriatric community, this could be considered the main way to go about managing geriatric problems. Geriatric assessment is evaluation and management. And so it involves gathering data, like finding the problems, creating a plan to address the problems, implementing the plan, and then repeating. It's kind of like what we do right now in CKD clinic, right? You check labs, you see the blood pressure, you adjust the medicine, you come back, see how things have changed. But I think the key thing here is that what the geriatric assessment does is just looking at the whole person versus, what we typically do. We're looking just at a few key characteristics that matter for managing someone's kidney disease. And I wanted to point out here that these components of a comprehensive geriatric assessment, where it's multidimensional. So if you imagine all of these components here, from functional status, falls, cognition, looking at goals of care and advanced care preferences, mood, polypharmacy, social support. It'd be great if we did that in our clinic, right? It's nearly impossible, one could say, but this is the components of a comprehensive geriatric assessment. And it's often multidimensional and interdisciplinary, because then you have those individuals who work in these arenas can come together and provide that type of evaluation and management for a patient. And so since that comprehensive geriatric assessment kind of was initially, framework was developed, and then several different studies have examined its benefit. There's a nice up-to-date article on this topic, which suggests it has shown some positive benefit and a few outcomes, as you can see here. And the way it's been implemented has varied, whether it's done in the home, hospital, post-hospital discharge, or the clinic. And to go back to some of these outcomes, it may not be across the board. So we're learning that it may not carry any benefit for someone who's already in a nursing home, who already has a lot of functional impairment, or individuals who are already on hospice, right? And then it also may not be beneficial to a patient on the other end of the spectrum, someone who's completely independent and robust. And so we acknowledge that it could probably have a benefit in a sweet spot of patients. And yet that could comprise a large subset of the patients we see in our CKD clinics and in our dialysis clinics. Given that, I've kind of alluded to some of the barriers to geriatric assessment so far. And so what we are dealing with when you think about this ideal way of evaluation and management of geriatric problems is that we are constrained by time, we're constrained by available personnel to conduct the assessment in the current setup of many of our clinics. And many of us, even if we had the time and the personnel, we're not quite sure how to even go about doing it. Like, what's the best approach? And then another thing that's to be discovered is really some strong evidence that it carries effectiveness and adds value to the care we provide, which could definitely motivate more people adopting it, right? And to go back to this issue around personnel, we have to acknowledge that it's not so simple as sending our patients to geriatrics, because that workforce is quite limited. Now, this is data from 2014. So if you can see from that data, both nephrology and geriatrics were kind of the least popular fellowship positions. And if we fast forward 10 years, that would mean that the workforce, especially in geriatrics, it has not grown. If not, it might be smaller. So I wanted to switch gears here and talk about some of the strategies that currently exist for managing geriatric problems. This is one study of a quality improvement program based in the UK. And in this program, they identified some patients to undergo frailty screening. And if they were frail, those patients had a geriatric assessment. And here, in this case, they had an occupational therapist do the geriatric assessment. And then the data was discussed in a multidisciplinary team. They developed a management plan. And I highlight this in part because there's very little in the literature how people are trying to do this. And also to acknowledge that geriatric problems are fairly common, as most patients had at least 3 of them. And what they weren't able to do is, in the study, is demonstrate benefit or any effect on outcomes. And then I can highlight what we've been doing in a nephrology clinic. We started the Renal Silver Clinic when I was still a fellow in training, and this clinic has evolved, but at its essence, what we do is geriatric assessment, and we use that to inform dialysis decision-making. We also use it to, just in general, for supportive care for all the patients, whether they're advancing to kidney failure or their kidney function is fairly stable. And a number of these patients are receiving conservative management. The appointments started out as 45-minute appointments. Now they're a bit shorter. I think they're 30 or 35 minutes. And it was staffed by myself and also an advanced practice provider who just so happened to have geriatric certification. And so we were able to, in this model, kind of address some of the issues of time, personnel, and we developed our own approach, which I unfortunately don't have time to go into great detail about. And a different model of incorporating geriatric assessment was conducted by my colleague Barrett Bowling when he was at the Atlanta VA. And in his approach, he created a triage template through which when patients presented to the CKD clinic, they asked him about certain geriatric problems, and he was present to review the data that the nurses collected, and based on the responses, he might tag a patient, briefly ask about the problems, and kind of have what I described here, brief unscheduled appointments, and then relay the abnormal findings to the nephrologist. Hey, and this patient here is having falls, for example. It's a way to kind of clue them in to the findings. So right now, as Renal Silver has evolved, we still do that. I mentioned the appointments are a bit shorter. And because of COVID, we actually are doing some of the appointments by phone, and some are in person. One of the shifts I made was to use the geriatric 5 M's in the clinic. And so my geriatric assessment has evolved a little bit. So because of time, I'm going to read these ends and kind of give you a sense of what we do in the clinic. Starting here with what matters most. Often what I do here is ask a patient if they have a preference in terms of whether they would prefer to live as long as possible or try treatments, and if they don't, like it, discontinue it. So try and get a sense if they have a leaning towards living as long as possible or quality or comfort care. For mine, I do a mini COG. This can be really quick because if a person can do a 3-item recall, then I just move on because I think that's appropriate. And for mobility, we ask about falls and any difficulty getting out of their neighborhood, so a brief life-based mobility. For medications, I inquire about whether they're managing themselves or is someone else doing it. And then kind of do a medication review for anything that's potentially inappropriate. In multi-complexity, it's kind of a hand-waving in, but I'd say for me, it refers to kind of taking in the patient in the context of everything else. There are other comorbidities and any psychosocial issues that might be playing a role in how they can manage their chronic kidney disease. Which takes me to this next point, is how do we even use this information in clinic? And I give a couple examples here. First, if someone has cognitive impairment, so either it's documented dementia, their mini cogs abnormal, or just something even just obvious from the encounter, then the issue that arises is we have no certainty that they're taking their medications as prescribed, and they're at risk of medication-related problems. And there's other instructions we would give our patients that honestly is not clear if they would acknowledge and take up. And then there's these issues about dialysis decision-making. Do they have capacity to make the decision on their own? Do they have behavioral issues that could affect their safety at dialysis? So these are the examples around cognitive impairment. And then we look here with respect to someone who may have functional impairment. It might look like having difficulty opening their pill bottles, being at a greater risk of falls, not able to prepare their own meals, and acknowledging if this is present, then this level of function may only get worse after dialysis initiation. So you can see this information can inform conversations around dialysis decision-making, but also put us in a position of being able to support the patient if these issues are present. So whether it's a referral for home health or communicating with the family about the patient's needs, do they need meals on wheels because now they're not eating because they can't prepare their food. All these things that could come into play such that what we expect our patients to do with respect to managing their CKD can actually be implemented in a way that is consistent with what we would expect, right? So we're trying to improve adherence to their CKD management, which has ripple effects here to, progression of their kidney disease and addressing any other complications related to their kidney disease. So what about dialysis? So I'm recognizing the time, but I'm going to try my best to gather the thoughts and not keep us too long. One of the things that I've been working on with respect to my research in general has been thinking about what's the best approach to do geriatric assessment in dialysis clinics. We have the same barriers in the dialysis clinics, right? It's not even more challenging because often they're siloed and not associated with a patient's like main hospital or electronic medical record, and physically siloed where there's separate buildings, different personnel than from the main hospital, for example. And there's not so much time when we're rounding through the dialysis clinics for long appointments or sessions. And then the setup around, there's not a lot of privacy either, right? And so I'll highlight some findings from one study where really think the objective in retrospect was to gain insights on how to design a geriatric assessment trial in dialysis clinics. This is the functional disability in dialysis study. We enrolled older adults, you can see the age here, to undergo like functional assessments. And also we approached these patients to also do interviews, and we interviewed some dialysis staff too. So about the cohort, one thing to point out here is, although we approached 61 patients and 37 consented, this is pretty good for recruiting older patients into a study. Their average age was 70, and we had good representation of African American patients. We conducted this geriatric assessment as this detailed here, where before dialysis, patients showed up early and underwent short physical performance battery and hand grip strength. And the median time to complete both of those was about 10 minutes. We were always able to find a spot in a dialysis clinic to pull this off. Often there's like a hallway where you can set up a chair, measure the 4 meters for the gait speed test, and complete it. So I'm pointing this out for acknowledging the feasibility of this, even though, yes, it was done by research staff. I think it's totally feasible in other settings or by other personnel. And during the dialysis, we had patients complete these surveys here in these different domains. Another highlight from the study is that we found clinically meaningful changes over time in our functional assessments. So just showing here that we did follow up at 3 months and 6 months with decent retention of the participants. And what we see here is that taking gait speed alone, we find that from visit 1 to visit 2 to visit 3, there were some changes. Some that were clinically meaningful, where they went beyond this bar, which was 0.1 meters per second, which would suggest a couple of things. One, people are having some changes within 3-month intervals. Some changes go up and down. And so that means that this may be things that we can intervene upon. And then last, I wanted to highlight some of the input we learned from the interviews, especially with respect to, like, if we were doing an intervention, what would be the preferences or concerns? So you can see that patients said it would be something else to add to my schedule. So some concern about how to add even more doctor's appointments. And another preference here is around being at home because it's private. There's many more, but I just highlighted a few here. And nephrologists, many concerns there was around how this affects their workload. So who's writing the orders? Who's going to be responsible for doing this? And the dialysis staff has similar concerns, but really around the fact that the treatment floor is the treatment floor. There's not room for much else to happen there. So saying that doing the full assessment is not possible on the floor. So the insights from this study, these studies combined, is that these objective functional measures like the SUVB and hand grip were feasible and subject to change. The stakeholders found it acceptable and important. I didn't highlight that before, but for the most part, there was some support for this and seeing its value. But the dialysis team truly needs support for buy-in. And so putting all of this together and seeing other examples of geriatric assessment, like in the oncology field, I have proposed a dialysis geriatric care model that allows the patient to do most of the assessment. So completing a self-assessment tool on a tablet, and then undergoing a prioritization visit where we really get to what matters most to patients with respect to prioritizing any geriatric problems that were found. And then we use that information to generate and deliver recommendations to the dialysis team. And then they can incorporate these recommendations into their usual workflow when they do weekly or monthly rounds, right? So this is actually proposed and was supported as far as the rationale in the R01 application, and we're looking forward to seeing a notice of award for later this year. And the concept behind this is, let's figure out what's the best approach for this and then pilot it. So my future directions, I want to highlight that really what we're still waiting to see is a strong evidence base around the effectiveness of geriatric assessment. I'm hoping I make the case that at the end of the day, it's still really important. However, I do recognize that having evidence will build on its ability to be disseminated and broad implementation, supported by policymakers, incentivize both clinicians in the CKD clinics and in dialysis clinics. And for me, I'm thinking about projects that are related to building capacity for geriatric assessment and reducing inequities. And these could be educational tools, so getting more clinicians in our field feeling comfortable with doing it, building the research infrastructure, which we have started through our Kidney Disease Aging Research Collaborative. I've been thinking about community engagement and how we can use community members to help. While we know we got limited personnel in all our settings, and also what can we do in our health systems as far as making these assessments feasible, having room for them, having it incorporated into the electronic medical record too. So in summary, I hope some takeaways for you guys is that geriatric problems are common and burdensome, and there is an urgent need to integrate geriatric assessment into our kidney care settings, really because it helps influence how we deliver care for these patients. And without some of this information, we're not providing the optimal care. And last, the barriers to geriatric assessment can be addressed through novel models of care. All right, so these are my acknowledgements. I include my mentors and collaborators on the projects I have listed here and my current funding. And I'll take some questions. And last, I'll let you know if anyone wants to scan this QR code, it takes you to a brief survey to give me some feedback and provide some comments. So thank you.
Thank you, Dr. Hall. Excellent. Thank you for this work. Clearly relevant to a growing population, not just those who are older. This geriatric syndrome clearly impacts a lot of patients across the age spectrum. Questions for Dr. Hall?
I have a question. I wasn't familiar with the GRIP test, and I thought it was intriguing to be using it in patients with dialysis. How is that? What's the scale, and seems like a really quick assessment, and would that be something that we could incorporate in our patients on dialysis, and how to interpret that?
Oh, yes. I'm so sorry I didn't have more details about that. So briefly, a hand grip strength involves using a dynamometer. And so, the cost for one may be around $300 or $500 for one that could be shared across the unit. And there's specific criteria for, how a patient's instructed to hold their arm and be positioned in the chair to hold the dynamometer in place. We do 2 tests, and you take the score, I think, of the second test. And there is actually a scale that kind of gives you a sense of whether it's high or low for a person's age and gender. And so I think that's my best description of how to do it in the short term. And I think there's some value to it in part because some of our patients have vascular disease and amputation. And so if you're trying to get a sense for a physical function, in all patients, you won't be able to do the short physical performance battery, which requires someone to be able to walk.
Thank you so much. And thank you so much for sharing your work with us.
Thank you.
Rasheeda, I'm curious, or sorry, go ahead, Dan.
Dr. Hall, wonderful talk. I am curious about whether alternative payment models such as kidney care choices have led to incorporation of kidney Geri sort of interprofessional services. I think you're probably aware that CKM services have been integrated in some of these participants. And I'm just wondering whether sort of valid-based models have led to testing of sort of better integration of kidney Geri services.
I think that's a wonderful idea. And unfortunately, I don't have a context for whether any of this has been started. But if you'd like to talk about it offline, I'd love to explore it and see if there are ways to implement it. I can imagine that part of impetus behind that integration is around the cost containment that would be a potential benefit.
Yeah, I think one of the challenges in fee-for-service is it's hard to pay for interprofessional services. And then in value-based payment models, you know, there is the potential for restructuring how you deliver some of that care that can integrate some of these services.
I see. Mm-hmm.
I was going to ask, I'm curious about your approach to your clinic, because there's been a certain amount of discussion about specialty clinics, especially in academic centers, and the specialty geriatric clinic for continuity has come up, I know, as one approach. But it sounds like you went with more of a consultation approach, if I'm understanding correctly. I just wondered about your thoughts on those options.
My impression is that there's not going to be one that's better than the other. I think the key is that you're collecting the information and applying it to how you manage the patient. And the scenario then allows for all the flexibility, no matter what your resources are, right? It could be a very low resource thing where you can have house staff coming in to do the assessment, right? And sharing the information and then discussing it briefly during clinic. So I'll see.
Well, thank you. Thank you so much for visiting us. Excellent presentation. And thanks to all of our speakers and for Nephrology Grand Rounds this morning. Everyone have a great weekend and look forward to seeing you next week.
Thank you.